class. So please come on the stage. Dr. Ma'am, Secretary, UP State of Health Society. Ma'am, please come on the stage and take your seat. Surgeon, please come on the stage and take. There is some slight change in the call. I would like to invite Dr. Madhu Bhaduria ma'am, who relax.
This is showing some different view over here. That this is my home, UP. I've been so far away from UP for most of my life. And even when I've been here, I've been so busy, I've not been able to meet you. Also, my apologies for that. And thank you, UPSOS and Shalini, for getting me here. And not for Shalini, I would not have been here. Now, I want somebody to help me come get this to slideshow. It's not coming here, it's coming a very different view. So, how do we go on slideshow from here? It's not slideshow, it's next slide. And I can tell you that. Why I'm telling you? Because if you keep quiet, everybody will keep quiet. Alright, so this is a very gold standard surgery, and I think that's something all of you know. But what we really need to know now is that anything which is old is not to be abandoned. We can improve and keep on improving. And in any glaucoma surgery, what do we need to actually improve? We need to improve the efficacy along with increasing the safety. So what has been done in this surgery over the period of years is been modified by a number of immunomodulators to make it more effective. And the same way with multiple closing techniques like sutures and different things that is being made safe. The other thing is that inner ostium gets blocked by multiple things. So also there are now donor procedures so that inner things are closed, then you can open them. So that's what makes this surgery really good, but all the same, we must remember this is a surgery where we are opening an anterior chamber. So it is to be done with all the precautions, and believe me, chances of losing an eye in trap are more than losing an eye in cataract. So we need to know simple things. Residents need to know when should we do it, what should we do, and how should we do it. So when do we do indications? When glaucoma is confirmed is my first thing to all of you. IOP raised, everything is normal, do a trabeculectomy, absolutely no. You've got to have glaucoma. That means out of 3 things that you have, IOP rise, this changes as well as field changes. Out of 3, 2 must be there for you to be thinking of a surgery at all that's confirmed glaucoma, right? Why I'm taking is a spectrum because NTG may not have raised IOP. Then you are not able to achieve the targets. ACG patient, no matter what you do, pressure comes not below 40. Or your patient is progressing now. Despite the target, patient is having fluctuations and progressing. Some patients have very large diurnal variations and they keep progressing. So we got to look for all those factors, not a part of this. Then drugs, we are not a very rich country. We love to write the best of drugs, but can they afford it? Can they buy from a place and it will remain patent? These are the only 2 things. So conjunctiva, what all can go wrong? We look at the left side and choose not 12 o'clock for the first trap. Either superior nasal, superior temporal. We don't choose inferior because it's open if you see here and prone to end off. So 12 we don't use because we can't do another trap after using a 12 o'clock position. Then we look for scarring. Many times I've seen students open up for SICS and it is a trap glare, right? So lift up the leg and look at the conjunctiva. Bad conjunctiva will be in your BKC patients, dry eye patients. So therefore in these patients we have to grade them as per the degree of difficulty and use anti-metabolites. See, this is Trabeculectomy. You see that flat leg. So all these conjunctivas, all these are different traps and they require special attention. Right? Counseling is very important because these patients can easily see you. We are doing it to preserve the vision. Despite the best effort, vision may be lost by a line or so. There may be transient diminution of vision in the post-op period, a little bit of hypema or a shallow AC. Second thing is these patients will require a follow-up for at least 5 to 7 days on a very regular basis. Not like a cataract, day 1, day 7 and day 28. It's not like that. It could be daily requirement at least for 5 to 7 days. And wipeout syndrome is a reality in advanced glaucomas, and they will not be able to wear contact lenses. Especially myopes are glaucomatous and they want to wear contact lenses, so these things need to be told because we are living in a world where swimming has become a fashion now. So this is Moorfield Safe Surgery System. I'm just telling you for the namesake for the kids. You can read from the VJO, very beautifully given, so I won't waste my time. But the crux of this is, in the information overload, there is so much written. Just remember, this takes care of two things basically: how to judiciously use antimetabolite, and second thing is how to safely use releasables and adjustable sutures or laser suturolysis. These are the two principles of the system. Rest you can read from the journal. Anesthesia, we can use perivulvar with Hyliase, but we never use aniline, we never use what else? Pressure. Because disc is compromised. In the compromised disc, short posterior ciliary arteries can actually get blocked by any of these. We can use subconjunctival, subtenon. Topical is pretty painful, but subtenon is really good anesthesia and it's not difficult to learn at all. Subtenon is very safe anesthesia and it gives very, very good results. Medication, we use pilocarpine to constrict the pupil. Brimonidine drug, nobody is thinking of this, but if you use brimonidine preoperative just half an hour before surgery, it reduces bleeding. Other than those things are like everybody knows, those are normal things. So conjunctival flaps, there are always controversies, limbal based, fornix based. Truly speaking, fornix based is a shade better, is easier to do, and there are other advantages also that you don't really have the posterior this thing. But limbal based is also extremely good if you have a person who's young, will not require cataract surgery for many, many years, and safety is a question mark. So this is how you cut conjunctiva. And here you got to make the pockets. These pockets are made, if you're seeing, I rotate the eye on one side, so it is looking 12 o'clock, but it's not 12 o'clock. The eye is rotated like that. You know, if you take a superior rectus and pull it down, you can pull it down towards nasally, the temporal will come to you, pull it down temporally, the nasal side will be there for you. So you make pockets, because in these pockets we are going to put the antimetabolite. Antimetabolites has to be very judiciously used. These days practically we need to use in most of the patients, but if a patient is very old or patient conjunctiva is very thin, it is better to avoid it. We have 5-FU, we have mitomycin C. Routinely these days we are using actually mitomycin C in different concentrations. So wound modulation, again some people are using under the conjunctiva, some under episclera, some are using after scleral dissection. I really feel when we are putting it subtenon under the flap, that is the best because you get a very diffuse bleb. Also point to remember that we have to have very minimal trauma. It's not that cut like that, expand rather than too much of just stretch, and if there is a tag, lift it up and cut it like that. And hemostasis, blood works like one antimetabolite. So if there is a bleed in your bleb, then it will work, it will bring all the fibroblasts inside and then you're done. So risk factors are 1, 2, 3, right? So NVG and all those secondary glaucomas, just remember one word, secondary glaucomas are all risk 3, right? So we will have to use 200 microgram mitomycin C, 3 to 5 minutes depending upon the conjunctiva status, how thick it is, how short it is. Then comes 5-FU. 5-FU is actually only one risk factor types you can use. There is no risk factor or one risk factor. I was using 5-FU long back. I don't think in last 10-15 years I've used 5-FU at all. And availability is also a question mark. Injections, 5-FU is good, post-operative doesn't work. And risk for, these things we talked about actually already earlier. What's happened? Why the slides are going reverse? Oh, sorry, my fault. My hand shifted to the other side. So, mitomycin C we use depending upon, this is clinical decision making that you got to see your teachers doing. What the conjunctiva is. You see the case pre-op on slit lamp, see the mobility, and then you see your teachers doing intraoperatively. And that is the best way to decide. There is no golden rule for it. So, high risk patients are these. Possible risk patients are these. Now, these are the patients we do not use antimetabolite. do no harm is the point to be remembered. So primary surgery, if you're doing in a myo, or you're doing in a patient who's got any collagen disorder, like ophthalmos, allied elros, or conjunctivitis very thin in very old people, and we don't place the blood intrapalpebral, so therefore only superior-nasal, superior-temporal. So antimetabolite, earlier we were using just one sponge. Now we are cutting it into multiple pieces and we are putting multiple pieces. Now here is one simile with gynae. Put in as many sponges inside, you count as many out. Leaving one piece of a sponge inside can lead to conjunctival necrosis, wound leak and endophthalmitis. This is the point I want everybody to remember. So must count no matter you're putting 3, 2, 4, 1. And also check again that no brittle piece has broken. Sometimes a small piece may break and stay inside. So newer modalities are these, but what I use is Avastin. I generously use Avastin by every possible mode. If it's an NVG, then it is an intravitreal. If there is a side port available, you can use intracameral at 4th, 5th day when you start seeing some vessels coming up, or else at the end of the surgery, intrableb it can be used. This drug causes no harm, and retina people have so much of it that you can just take from them without paying them anything. Just take from a retina colleague and just say like it's good for my patient. But the role is when the blood vessels are coming up, you follow your blebs. And it can be given in intra-bleb even after the surgery has been done. 4th, 5th, 10th day, the failing bleb sign is a corkscrew vessels coming up. That is the time if we give Avastin, we take care of those corkscrew vessels and do a nice massage. The trap works. So side port is practically mandatory to make a side port in this, but side port of this is little different. We don't make a big side port. We make a small side port, and you can use anything like air. Visco can be used, but only a Hedon in certain cases. Those cases I will tell you later. Is clear corneal, self-sealing, parallel to iris. It's not so parallel to the cornea, it's parallel to the iris, and not more than 1 millimeter broad. You can do irrigation, AC wash, bleb formation. Post-operatively also, if you need to give something, you can do. Or suppose sometimes your iris goes and gets inside the bleb, you can pull it down through the side port. Viscoelastic is good for corneal protection in a very shallow AC, or a patient has got NVG, or whether AC will be filled with the blood, or you really need a firm eye, right? It will prevent your hyphema, lens injury, choroidal effusion, and post-operatively also. The eyes have a better bleb if you use Hedon, but I don't advocate methyl cellulose, it's very inflammatory. And Hedon only, and it's good to use this in myopes. Younger patients, especially high IOP. High IOP is staying for a long time, eye becomes very, very brittle and tends to have a choroidal effusion. So therefore, these are the indications when we should be using Hedon, but not in all patients, just these 3-4 indications. AC maintainer is a 4 bands Hedon, and which is helpful, which is really helpful. Flaps we can make triangular, we can make quadrangular. I make both, I don't know in whom what I will make. No matter how large a flap you make, it is your inner ostium that will decide. It is the titration between the inner ostium and the outside flap. A thick flap will reduce the filtration, a thin flap will facilitate. So size, shape has to be decided, but you do not make a flap less than 3 millimeters ever, and normally a good flap is 4 to 5 millimeters. You all should make 4 to 5. And cataract surgeons can actually use all the cataract instruments to make a, just like you make a tunnel, make a high tunnel and use a crescent plate and reach till the cornea. See, this becomes a quadrangular flap, so this is a good thing for the people who are using mainly cataracts and lesser traps. Those who are doing more traps, by and large people are making trabeculectomies. And then with a punch, you can just get 1 or 2 punches. Normally I take 2 punches. You have to cut a sclerolimbal junction to corneolimbal junction. There has to be a clear ostium, and then we do a PI. In this speed, 2 edges have to be definitely sutured. In this, 1 suture will not work. And in between these 2, you can take as many adjustables or releasables that you need to have. So in this, I think I'm taking 1 fixed and 1 is going to be a releasable. Inner flap stitching is always with non-absorbable, so it's usually 10 or nylon. Now the internal sclerostomy. Internal sclerostomy has to be patent. We have to see intraoperatively is patent, and also if it's an angle closure glaucoma or NVT, it has to be placed anteriorly because there are so many synechia, the iris is glued, so therefore it doesn't remain patent if it is very posterior. Then sometimes in NVT you have the angle full of blood vessels, and if you cut an inner block, it bleeds like hell. So we can use the same DLCP laser to the inner bed at half of the at half the power. Like we use 1600 for that. Here about 700, and we do a laser and then we make an inner ostium. We prevent all the bleeding. Residuals are must. Why I am showing this diagrammatically to you all? Because this is something you need to understand. People will tell you lots of fancy things, but this is the simplest. A suture through cornea, which is buried in the cornea, through the flaps, tie a knot, simple knot, that is releasable knot, and cut the buck at one end. Make sure that it is tight enough. 3 to 4 throws depends upon how tight you are going to make them. If you are really making them very tight, 3 are fine. If you are really loose suture surgeon, then make 4 knots. After putting a releasable, that's okay. So here you take it through a cornea. You take this shaft through clear cornea, because if it stays outside, then you will have the Viper syndrome and there will be rubbing of the cornea. Then you will take from this end and you will take from the other end half thickness. Try not to hold the edges of the flap too much. Try and use the counter pressure to dig in. And slowly remove the needle in a rounded manner and not pull it like that. Because you can make the trap bigger and that trap leaks. And especially after using mitomycin, see that leak from the trap can also become disastrous. Then you look for this little loop. Yes. And after that you check from there it's releasing. And then you cut the end which is not towards the cornea but towards you. So you cut this end and leave it over there. And then again you trim it over there. And with the side port, now you nicely make the AC and hydrate the side port. See, now make the, and after trap, never leave the AC firm. Never leave the AC soft. It has to be made firm because then only your trap will function. In the soft eye, the inner ostium gets totally opposed and it gets blocked afterwards. Oh. Conjunctival closure here is very different. It's not like it's in this only, sorry I didn't see that. So you start at one end and you have to take a little bit of portion of cornea when you're moving forward, because if you don't include that, it retracts back. Like in SICS, everybody is holding at two ends or giving a subconjunctival on the top and it covers. It wouldn't stay like that. So you take from here a nice bite at the limbus, because this will have to be your anchor. If it is not properly anchored, then conjunctiva will open up, and after metabolites, if there is a leak from here, the bleb will never form, and then there will be a lot of fibrosis, and after that fibrosis it will be difficult to retrieve your trabeculectomy. So just want to see a few points here, that from limbus you are coming here, then from here we go back to conjunctiva, to the cornea, so that it's anchored there. Some people can take also a mattress at the bleb forming, but I prefer continuous because the knots are buried both inside, so patient is very comfortable. See that if you take it like this, and then from the middle you pull the suture, you just see over here, there will be, okay, this is ending over here. So from the middle, in the two ends of sutures, you pull that thing and put a knot goes inside, so there is no knot, the patient is very comfortable. So take home, do only surgery after confirming glaucoma diagnosis, and there is need for surgery. Do it meticulously, follow post-operatively, very carefully, daily at least for next 5 days. Complications do occur. Must learn to anticipate and manage, and don't get frightened. Only those who operate will have complications. Non-operating surgeons only will be who will never have complications. Be careful. glaucoma patients are patients for life. So you can't say did a cataract, they would never come back to you. They will trouble you till you die or they die, one of you. And post-surgery glaucoma follow-up and watch for progression will continue as before. Surgery is only to stop the progression. So with that, I would say a very good thing. Thank you to you. Complications are lots. I don't want to frighten you in one go. Next time you come.
Well, even the first years would have been, और हम लोगों ने तो बहुत कुछ मैम से सीखा है, and even now, whenever I have any problem, immediately I call her and she actually helps me a lot. Now we would request you to receive a memento as a token of our love and gratitude. I would request Dr. M.C. Saxena sir and Dr. Mohita ma'am to present a memento to Dr. Madhu Bhaduria ma'am. Ma'am, Madhu ma'am, I feel as if the boss has come over here. President was, the secretary was. Thank you so much. I would also request everyone to kindly stick to time so that